Next, we have Dr. Joshua Wynne, the Vice President from Health Affairs and Dean of the University of North Dakota School of Medicine and Health Sciences. A cardiologist with extensive experience in academic healthcare, Dr. Wynne has a background in clinical care, research, and teaching, and holds an MBA from the University of Chicago and an MPH from the University of Michigan. He completed his residency in cardiology training at Harvard Medical School's Brigham and Women's Hospital, and has served at UND for the past 15 years. Please welcome Dr. Joshua Wynne.
Well, thank you, and good afternoon, everyone. I actually stepped down from my administrative positions on December 1st, but I'm still a full-time faculty member at UND. What I've been asked to talk about today is the particular considerations in more rural parts of North Dakota, but as you'll see, it's generalizable to everywhere. And is this how I advance? No. Slides advance? What do I do? This? There we go. So what I hope to do today is to give you a little bit of sense of the state of health and healthcare in rural North Dakota as it relates to the heart, and go over some of the special challenges and opportunities. I think there are two factors that are especially important for rural folks with heart disease. One is that time to treatment is critical for specific conditions when they occur acutely. So the Rock the Heart is related, it was founded because of a patient with an enlarged aorta that is prone to rupture. If that occurs, that is a true medical emergency, and time is of the essence. As I'll discuss, it's also true of heart attacks. So how we manage people acutely is critically important. But there's a second component, and that's the ongoing surveillance that we do to anticipate problems. So let me go back to the aorta as an example. The aorta is the big blood tube that comes out of the heart, as you know, and in certain conditions, some of them genetic, some of them acquired, the aorta enlarges. Now, the acute thing is when it tears, and that is a true medical emergency, and it often has a very bad outcome. But the surveillance part is essential because we now know that if we discover an aorta as it is starting to enlarge, we have excellent guidelines as to when we need to intervene, which means to fix that aorta before it gets to a size where it's likely to tear. So surveillance can prevent the acute problem. So we have to be able to do both, and both can be challenges in rural areas. So I want to tell you a little bit about what we're doing and what we can do in the future. So one of the things that you may be interested in, if you go to the UND website, is this report that we do every 2 years called Health Issues for the State of North Dakota. And we have a team that accumulates data from all over North Dakota and presents it on the website in a very digestible format. And it can tell you about what's going on in North Dakota. So just go to UND, the School of Medicine and Health Sciences, and then go into publications. And I've included the link here, but you can easily find it on the web. Now here is the challenge, if you will. This is looking at the population density in North Dakota. And if you go all the way out to the west in Slope County and compare that with Cass County, the difference in the number of people per square mile is 150. So here in Fargo and the region, we have 150 times more people per square mile than all the way out west. So you can see that the population densities are largely around the 4 bigger cities, and then it can really fall off in the rural areas. And related to this is shown on this slide is the provider in this case are physicians, But I will tell you the same thing applies if you look up nurses, physician assistants, occupational therapists, et cetera. There is a much greater density, and this is corrected for population. So obviously there are more doctors in Fargo. But if you look at the number of doctors per population, we still have many more here than in the rural areas. Notice the difference in the bars. Now, we don't do too badly compared with other parts of the country, but this is a ubiquitous finding that there is a maldistribution of providers of all types, with the concentration in the more urban areas and a relative shortage in the suburban areas, and especially the rural areas. So that's part of the challenge, that the providers just aren't there. And again, it's across the board. Some are better than others, but for all of us, we tend to be where there's more population and there's a real shortage in those other areas. Now, as a consequence, this shows the density of physicians per population. So I want you to notice, again, you could probably pick where Fargo and Grand Forks and Bismarck and Minot are located. But notice out in the southwest, out there in where Hettinger is, do you see the one second from the border? Just above South Dakota? I don't know if I have a pointer. Okay, that's Hettinger, North Dakota, and the West River Medical Foundation, Medical Care Group is there, where they have a concentration of physicians and other providers. So that part of rural North Dakota actually has figured out a way to get providers located there. So I'm very proud of that, particularly because many of the providers there are graduates of your UND School of Medicine and Health Sciences. So the problem with providers being maldistributed in rural areas is not everywhere in North Dakota. It's many places, but Hettinger, you got a lot of people there. They've figured out a way to do it. The other thing that I just want to remind you is that part of North Dakota is Indian country. Here are several of the tribal lands, and the next slide I hope will astound you, because this looks at the mortality figures for Native Americans in North Dakota versus the rest of the population, and you can see it's roughly double. So there are all sorts of reasons for that, but problems with healthcare delivery in rural areas, particularly on the reservations, is a major issue when we're working to try to improve this situation. But this should not be. I think we would all agree we have to do something about this. There are other additional considerations in rural areas. People in rural communities tend to be older and poorer than those in urban areas, and behavioral health issues are not just a problem in the cities, it's true throughout the state. Staffing can be a challenge. Distance is a big deal, particularly during inclement weather, and emergency medical services can be a problem. That's a whole other topic to discuss. And then financing. So we rely on roughly 3 dozen so-called critical access hospitals in North Dakota that are small. They're limited in their number of beds, and they have a special way of getting reimbursed. But it isn't working optimally, and many of them are facing financial challenges with all of the activity that's going on now to try to eliminate some of the waste that people believe is in the government. I'm just concerned about those rural hospitals because some of them are already struggling financially. So if you have an interest in that, you might want to pay particular attention to the funding for the so-called critical access hospitals, because they provide an important link in providing health care in rural North Dakota. So let's go back to my earlier slide where I divided things into the acute problem and then the surveillance one. So what are some of the heart conditions where time is of the essence? Well, obviously, you all know about heart attacks, where we have a interruption of blood flow due usually to a plaque that's formed in the artery, and a superimposed blood clot forms, and it may largely or completely stop the flow of blood to the heart. If we don't restore blood flow to the heart within a relatively short period of time, that heart muscle dies. And that can lead, obviously, to serious problems. So we have this expression of time is muscle, and what we need to try to do is to get that artery opened. As I'll talk about in a subsequent slide, there are two major ways of doing that. For those of us who live close to a major hospital, the preferred way is to have Dr. Go or someone else go into the artery and put a balloon up and a stent in to get rid of the clot and the plaque buildup so that we restore blood flow. And we like to try to do that within 90 minutes. We know if that can be done, then there is a very good outcome in most cases. But what about in rural North Dakota? And it's the middle of January, and there's a snowstorm. What do we do then? Well, there's actually a not bad alternative, which is we can give what's called a clot buster medication. It's given into the vein. You don't have to get into the coronary artery. And as I'll show you, it's not as good as doing a stent, but it isn't bad. So one of the things we need to do is to make sure that we can figure out how quickly can we get a rural patient to a major center. And if we can't do it in a short enough window, then it's clearly better to give the clot buster and then maybe refer the patient when they're more stable and so forth. I'll go into that a little bit more later. Another big one, as I talked about earlier, is aortic dissection. This is an acute tear in the wall of the big blood tube that comes out of the heart, and that has to be dealt with emergently. Another one is when a patient gets an infection of a heart valve, where the infection, the bugs, can actually destroy the valve, typically leading to severe leaking of the blood back to the other chamber. And then people can have irregular rhythms. They can be too slow, or they can be too fast. And in the case of the slow heartbeat, the way we would fix it in a big center is to put in a pacemaker, but you're not going to do that in Hettinger, North Dakota. So what are you going to do? I'll show you in a second. And then there are fast heartbeats, which can be managed with medications or a shock. Let's go into this a little more, as I was talking about. So here in heart attacks, we can use a clot buster medication given in the vein in the local hospital. It's probably about 85% effective, or 80%. Stents are over 95%, but 80% is better than zero. So if you have a patient, if we have a patient can't get to a big center, we can use the clot buster and then transfer the patient electively, and that's pretty good. You know, I think it was Aristotle who had this expression that the enemy of the good is the perfect. If we try to transfer every patient with a heart attack with a stent, for a stent, a certain percentage of those people are going to arrive late and with totally occluded arteries. It's much better in such situations to use the clot buster. And you need an established protocol where you know how long does it take to get from A to B, and you need that protocol. We have that in North Dakota. Second big problem, as we talked about, is aortic dissection and leaking of the heart valves. This is one where there isn't a good alternative. So if that happens out in Rugby, that patient, one way or the other, really needs to get to a larger center. Unlike with a heart attack, there isn't a good alternative. For the unstable rhythms, we do have things that can be used in rural areas. We even use them in big cities as a temporizing method. Slow heart rates, we can use an external pacemaker until the patient's transferred and gets a permanent pacemaker. And for the fast ones, we can use a shock, a defibrillator. I'm sure somewhere in this hotel we'll see a sign for an AED, automatic external defibrillator. So if I keel over as I'm giving this talk, please find the AED that's out there in the lobby or someplace, because that's what I need first. Before you transfer me to Essentia or Sanford, I need the defibrillator, and I'm sure there's one somewhere around here. And then rural patients, as I mentioned, surveillance is really important. If you have an aorta that's a little enlarged, we need to follow that. If you have a prosthetic valve, as was discussed on the anticoagulation question, we need to follow that valve to see if it's having any problems to prevent an acute problem. So how do we do that? Well, I think a really good way is coordination between the local caregiver in the rural community or elsewhere with a larger center. So I just came from my clinic, I'll show you this in a little bit, where we take care of patients from all over North Dakota who have congenital heart disease, but they're adults. So they've grown up with problems with their heart, and I, in combination with a pediatric cardiologist, take care of them, and we typically see them once a year. But their day-to-day care is in their local community. They're in Rugby, they're in Hettinger, and so forth, and those providers coordinate with us as need be. For the big decisions, a valve replacement, this operation, that operation, we need to be involved. But for the day-to-day surveillance, that often can be done in the local communities. One of the things that's really helped, particularly with rural patients, are so-called wearable devices, including Apple Watches. So let me tell you about a real patient. This is a young patient of mine with a prosthetic valve who sent me a MyChart message. So the patient typed in a message and saying, hey, I'm having some extra beats. I can feel them. My heart is skipping a beat. So I wrote back, again, I haven't seen the patient. I'm doing this over the chart. So I wrote back and said, oh, we need to see you. We need to get an electrocardiogram. We need to have you wear a monitor. And he said to me, as if he was talking to someone who was not very bright, he said, why? I can send you the recordings, the tracings from my Apple Watch. And he did. And here's the tracing. So what you can see, the 1, 2, 3, the fourth beat, that's an extra beat that we call a premature ventricular contraction. I looked over the entire tracing. He didn't have anything that looked dangerous, but I knew what this problem was. We knew how to treat it. I put him on the appropriate medication, and his symptoms went away. So that's an example of how we can use technology to extend the reach of a specialist out to the rural areas. So in monitoring and management, coordination is key. Wearable devices really help, and selective use of telehealth, where you see a patient on TV, talk back and forth, can be very useful. For surveillance, periodic imaging is important, and some of the imaging we do in the local communities, and then they electronically transmit the tracings to us for us to look at, just the way my patient did with his Apple Watch data. So, for certain conditions, such as the ones I've talked about, the partnership of a local provider in Rugby, in wherever, and a large referral center is ideal. So I mentioned, literally an hour ago, I was in the adult congenital heart disease clinic, where we have a team of pediatric and adult cardiologists who are familiar with a wide spectrum of congenital heart disease. There are structural heart disease clinics and heart failure clinics. But again, I want to emphasize that this is not an either-or consideration, it's an and consideration. You can provide a lot of the care in the local community, coordinated with, as need be, a larger referral center. So, in summary, there are a couple of things we can do to help the overall situation in North Dakota. Number one, we can increase the supply of providers out in rural areas, and we're doing that through the so-called Healthcare Workforce Initiative, where we're expanding the number of medical students, the number of residents, that is, students who have graduated from medical school and are specializing in an area. We have offered financial incentives and a whole bunch of other stuff to get more providers in North Dakota and especially in rural areas. And we do it through the UND School of Medicine and Health Sciences, and DSU Pharmacy, and a whole variety of other institutions. And by the way, North Dakota is considered to be pretty attractive for providers. This is a survey that was done of physicians, in this case, in a so-called Medscape review, where they every year look at where people in the state say they are most happy. And so they looked at the North Central region, and number one on the list was North Dakota. So we are having more success in keeping providers here and attracting them here. The second is to try to reduce the amount of disease out there, to reduce the demand for services. If we keep all of us healthier, we don't need doctors and nurses. So we really need to emphasize those preventive aspects that I talked about before. And then finally, in addition to increasing the supply of providers and reducing the amount of disease out there, we need to really work even better on how that interacts in the care delivery model. And I've touched on some of the points, but here are some of them, including using interprofessional teams, including using artificial intelligence. We talked about wearable devices and telehealth. So we're doing a lot. What should we continue to do? Well, we should continue to implement that healthcare workforce initiative that I mentioned to increase the number of providers and attract them to rural areas, and work on how we can make care delivery even more effective. That's through more interprofessional teams, the use of artificial intelligence, wearable devices, and realizing that virtual care, telemedicine, is not an either-or proposition with an office visit. I like to think of it as an and, that we need to do both. So that's a brief summary of my take on healthcare delivery in North Dakota, and especially in the rural areas. And I think that we've made things better. We still have a ways to go, and I've outlined some of the areas where I think we can make even more progress. So I thank you for your attention, and when we get to the question and answer period, I'll be glad to try to answer any questions if you have any. So thanks so much for your attention.
Thank you for being a part of the Rock from the Heart community and for joining us today. Your presence and engagement make a huge difference in raising awareness and building a stronger support network for those affected by aortic and heart valve disease. Thank you so much for attending today.